everybody. Um, Welcome to today's PLI, which is based around all the different cases specialities. So, introductions. My name's Emma Park. I'm the clinical lead for cases and a peer reviewer for gynecology, and also the clinical lead for sexual health in the community. And we have a lovely stall at the back where you can get lots of goodies. That's the agenda, which you should have all been emailed out. We're not planning any fire alarms, so please exit if the fire alarm goes off. And apparently there are toilets. Okay, so I thought I'd do just a little bit of an introduction about cases, which I'm sure you're all familiar with. As you may or may not know, cases was originally set up as a pilot, and the idea was that it was to try and streamline the patient and the GP experience. So the intention was that we would have a team of peer-reviewing GPs who had an interest in the speciality in question, being mentored by consultant specialists in order to review GP referrals to make sure that the patient was being directed to the most appropriate clinic in the best and most streamlined way possible. We have several of our peer reviewers today who are going to present. One of the other things was that the learning that we were supposed to get was to feed into pathway development and to try and improve care across the city. So as you can see from the data, we actually pass the majority through because actually the majority of referrals that we make are completely appropriate and going in the right place, and there's not a problem. And the aim is not to try and decrease referrals or decrease pressure on secondary care by sort of stopping people going. The idea is to make it count. So the example I can always think of is, so I'm a peer reviewer for gynae, so all of my examples will be gynecology related, is that we find that patients who are being referred with consideration of PMS or premenstrual dysphoric disorder, what used to happen is that they would go up to clinic without their diaries being completed. They would see the consultant who would say, well, I can do nothing. You need to go away for another 3 months and complete the diary. So that's 2 hospital appointments. Now, if you refer it through, hopefully a cases peer reviewer will pick up that a diary hasn't been done and send it back. We'll probably still pass the referral through, but at least that means when the patient gets to secondary care, they've got their 3-month diary completed, and so they can have their treatment and diagnosis and everything done in a oneer. So these are the referrals that are returned, and usually with advice. So interestingly, the highest is respiratory. So I know that we're looking at, for the next series of PLIs, to do one on respiratory. And we've been tailoring the PLIs and the education we're doing according to what we're seeing in the patterns. So I don't know if you're aware of this, but we have produced a number of webinars which are all available on the PCS website. And again, this was in response to data that we were getting from the referrals of things that we noticed that GPs were either finding difficult to manage or that they were struggling to understand the pathway. And then we've fed into pathways developed in primary and secondary care, which are all on the press portal. So I'm not going to go through all of these because you'll get the slides and hopefully the links will work, but at least you will see the breadth of things. And one of the things that we've noticed is that we've spotted things that perhaps we weren't aware of. So again, and these are still sadly in the pipeline because I haven't been able to get the people in question to agree, that there was a discrepancy between how radiology were interpreting ultrasound reports and how gynecology were interpreting ultrasound reports. So you can imagine, as a GP, it would be very difficult not to refer somebody up to gynecology if you've got an ultrasound report saying refer to gynecology. But the gynecologists were saying, why is this person here? They don't need to be here. So we've tried to get radiology and gynecology in a room together to agree some guidance. They're still fighting it out. But watch this space. Maybe in 2 years' time, I will finally have a document for you. I've only been working on it for 3 years already. But again, so as I said, further plans. We've got gynae radiology, we're fighting it out. I'm hoping you'll have seen I put out some HRT unscheduled bleeding guidance that went out in Team Talk. That's going through the clinical reference script to try and get it on the press portal. There's a groin pain pathway, which Humphrey, our peer reviewer in general surgery, has just submitted to the CRB, so maybe in a year's time we'll get that on the press portal. And we're going to have more webinars and updates in the pipeline. If there's anything, a clinical topic in one of the specialities that you think I would like to know more about or I would like some training on, please let me know and I can see what I can do. Okay. And if you've got any suggestions or queries, that's my email address. And now we'll hand over to the urology peer reviewers.